Dr. Pereira, it's 12. In the interest of time, do you want to start or do you want to give some late arrivers a few more minutes?
We'll start. Just start
Yeah.
with presentations and perhaps the case starts in a few minutes. What do you think, Mari? Can we start? Mari?
For me, yeah, for me it's okay.
It's okay, so let me introduce you. Dr. Mariana Kumaira Fonseca is our presenting for the SPITE, the Brazilian Trauma Society today. She's from Porto Alegre, in our southwest state in Brazil, and they have a huge trauma center there. They are in both, of course, not only o Hospital Pronto Socorro, but also o em inglês eu não sei falar como que é o
Isso?
Cristo Redentor. Yes, Cristo Redentor sem traduções. No translations for Cristo Redentor. They have two big trauma centers there, and I'd like to thank in advance for Dr. Mariana for his kindness in accepting our invitation. Thank you very much, Mari. So please, we don't have any panelists that are available. So anyone who wants to make your comments, please raise your hand, and Kevin will allow you to participate as a co-host, and then you can talk.
I went ahead and made some of our regulars co-hosts, Dr. Untrack, Dr. Frisbee, Dr. Hoffman.
Okay.
They're all ready to go. But if there's anyone else who has any comments or questions, just
yeah, I'm seeing people from Brazil here, from
okay.
Hospital, probably the state of São Paulo, and other people here from many other states. And perhaps if you want to make any comment, please raise your hand, or you can write in our chat, and we'll continue. So we should start now. Let's start, Mari. Go ahead.
Okay.
Thank you.
Thank you. Good afternoon, everyone. So my name is Mariana. I'm a trauma surgeon from Porto Alegre, Brazil. And I'm happy to be here again and present another case in this meeting. So today, our case is from an 8-year-old female patient who was a pedestrian struck by a bus. We actually got the footage of the accident. I got it from the news.
A menina corre.
Oh, let me just take off the audio. So she was running and hit by the bus. Then she fell, and the rear wheel of the vehicle, the bus, ran over her pelvis and abdomen. There, one last time. So she was running, then she fell, and the wheel passed over her abdomen and pelvis. This happened in a metropolitan city near Porto Alegre, and she was first seen at a regional hospital in the same city. So she was referred from this hospital, which is about 32 kilometers from our hospital. We got the reports from her initial assessment and management at the referring hospital. She was first transferred to the pediatric ward. She was denied access to the ER because they said they weren't supposed to care for pediatric patients. So she had a patent airway, a cervical collar that was placed by the pre-hospital care team. There are no records of her vitals at arrival. She had a Hudson mask, was saturating okay, but she showed signs.
I think we lost Dr.
Oh yeah, I thought it was me.
No, I think she's frozen.
Okay.
Oh, there she is. She's back. She's back. We lost you for a few seconds, Doctor. You were frozen. Yeah.
You stop in C with no vital signs.
Okay. They have no records of her vital signs at arrival. She was pale, cold and clammy extremities, showed these signs of shock. Her Glasgow was 11. She was agitated and complaining of abdominal pain. And they questioned possible minor bleeding at the vaginal meatus, urethral meatus. So they got an IV access, and they said that they made a push of saline, 20 milliliters per kilogram, and they got her in the CT scan. During the exam, she was agitated and showed signs of worsening of hemodynamic deterioration. And then they decided to perform the intubation at the radiology ward. They did another push of saline and ordered packet red blood cells. So the report from the CT scan from the referring hospital showed right renal cortical irregularities, a urine leak at the renal pelvis junction with the proximal ureter, and a hematoma along the way, and there was a pelvic fracture. No signs of head injury or thoracic injuries. They decided to stabilize the pelvis with a sheet and decided to transfer the patient to our hospital. She arrived about 4.5 hours after the accident. So upon arrival here, she had a secure airway with the endotracheal tube, no cervical collar. They removed it after the CT scan. She was in mechanical ventilation, had normal breath sounds bilaterally. Her heart rate was 139, blood pressure was normal. She had cold extremities, and a capillary refill time also prolonged. She had palpable peripheral pulses, a distended and tense abdomen. The pelvis was stabilized with the sheet. She was sedated, and we noted a hematoma at the left vulvar region, an abrasion over the left iliac crest, and an ecchymosis in the left lumbar region. I don't know if anybody wants to
participate. Let me ask you, we have some very good people, Mariana. Please, anyone who wants to make your comments, raise your hand. I'm not sure Dr. Ontrach will be able to be with us. Stephen, can you comment on the case or in the American College?
Certainly. It's really chilling to actually see the accident. Normally, you hear the stories and the facts and you realize, well, it must have been really something. But this case is too bad. That intersection had if I recall correctly, a paved sidewalk, and child should have been walking. Don't show that video to her parents, because she's going to get such a whipping for walking off. She was walking on the sidewalk. She was just she was off the sidewalk when the bus came around. She's going to get such a whipping from her parents. I hope the trauma from the whipping is not as severe as this, but it's just amazing that they're run over by the rear wheel, and she was stable enough to make a 4-hour transfer. So, I think they did a good job, except the denied access. Somebody, if they get a call, an 8-year-old run over by a bus, and they say, well, because they don't treat pediatric patients there, is that the issue? But still, they're doctors and nurses. They can be sure that the ABCs are okay, and then decide to send her perhaps to the pediatric floor. But I don't understand that, and that might be a subject to take up with the director of that referring hospital. I mean, she did okay because of her injury, but if it was a different injury, that might have made the difference. But so anyway, I think your vital signs look good. The heart rate of 139 in a pediatric patient, I don't think has the same import as in an adult patient. The blood pressure is okay, but she's still showing signs of shock with a delayed capillary refill, cold extremities. And they did a good job of giving her like a couple of pediatric units, 1 or 2 pediatric units of blood. That was good. And I would certainly reevaluate. She's probably stable enough. She's intubated. She can go to the CT scanner to rescan. But I would, even if I decided to do that, I would still look with the ultrasound. Distended tense abdomen. She's probably bleeding there now, and you need to see where she's bleeding. The original scan showing disruption at the UPJ, I assume that a good pediatric urologist can put a stent up into the pelvis if they're still in continuity. That would be the best thing to keep the kidney drained, and then it leak. If it's an in continuity leak rather than total disruption, that will heal. Otherwise, they'll need to put a nephrostomy tube and arrange some reconstruction later. But I'd be concerned about new bleeding, and so I would do an ultrasound, and then, unless it was obvious from the ultrasound what you need to do, I would do a CT scan to find out whether she needs a control of pelvic bleeding in the IR or something else, some other solid organ bleeding that you need to do a laparotomy for. And of course, I would have the blood set up, but I think she's lucky in this case, but she could have been a lot luckier and been a few minutes late, a few minutes early, or completely on the sidewalk looking behind her. And I don't know if she had music in her ear. She's 8 years old, so maybe she didn't and should have heard the bus.
Yes, might be a possibility. Yeah, Dr. Hohan, can you comment? Horacio?
Sure.
Thank you.
She's surprisingly hemodynamically stable. That's the part that I'm very surprised. I would like to see at least the plain films of the pelvis to get a better idea of how unstable that pelvic fracture is. There are a few things that are concerning. One is the abdomen is distended now. She got blood, so she might be bleeding in the abdomen, and it might bleeding from the pelvis with a ruptured peritoneum bleeding into the abdomen, or can be a traumatic injury in the abdomen. If we have to guess, based on the report of the CT scan, it's probably from the pelvis. And this creates a problem because you don't have a tamponade on the pelvis. So this patient will continue to bleed until the pelvis is stabilized and embolized. So I agree with Dr. Untrach. The FAS might be positive, but you still don't know where the bleeding is coming from. You have a CT scan that showed no other solid organ injury, so you have to assume it's coming from the pelvis. Otherwise, 70% of them will be coming from a solid organ injury inside the abdomen. So the FAS, yes, is useful, but not so useful in terms of determining treatment. If you have a pelvic with a pelvic fracture and it has a positive FAS and it's hemodynamically unstable, that patient needs to go to the OR because 70% of them, the bleeding will originate in the abdomen. But in this case, you know that the abdomen appears to be okay and the problem is in the pelvis. So if something ruptured is coming from the pelvis, it's allegedly. So the priority here will be controlling the hemorrhage. This is a kid, so it will become unstable later on. So this is maybe metastable. As Dr. Untrach already pointed out, she's still in shock, even having a normal blood pressure and normal heart rate for a kid this age. So my first concern is determine where is she bleeding from, and I will be worried about bleeding in the pelvis. So a patient like this, first we will get the pelvic film to see how unstable is the pelvis. Some of the pelvic fractures are not well stabilized with a binder, but some of them are. So we don't know what type of fracture she had. I have to assume she was run over in an AP direction that the pelvic binder will work, so we will replace that for a regular pelvic binder. But if she was on her side, it might not be so effective when she was run over by the bus. And from there, probably to interventional radiology for embolization. That would be the course, and after that, go for the rest. These are very serious injuries. If she has the ureter is dissociated from the bladder, that will be bad. And the fact that she has blood in the vagina and the urethra is really bad. That's all I have for now. Thank you.
Thank you very much, Dr. Hohan. I don't know. I'm not sure any other doctor would like to comment. Let me do just a comment. The urethral injury in women and a girl specifically is very rare, very rare. Perhaps you have a bladder injury, perhaps retroperitoneal, and just a small volume of urine around. But I would suspect, even it being rare, that the urethra is eventually injured. Another thing that you have to add is that when you are run over like she was, there is the movement, the rotation of the tire on the skin. So the skin and the subcutaneous, they detach from the aponeurosis. That is called Morel-Lavallee injury. And this eventually has a potential to be another source of bleeding. I go strictly our previous comments there. They did anything I would do. So if you can continue, Mari.
Excuse me, Dr. Pereira, what's the name of that injury again? The degloving?
Morel-Lavallee, MORELL/Lavallee, LAVA. I think it's that.
Is eponym. Is that named after some surgeon?
Yes, it's eponym. And this is a very, very specific injury. You only have this rotation. The tire has this the force that is applied here is you can detach it.
You mean degloving? Is that what you mean to say? Is that it? Oh, Morel-Lavallee.
Lavallee.
Very good.
Roberto Calderon. Thank you very much, Roberto.
I guess they did. I'm glad they didn't ask me that on the boards. I would have gotten it wrong.
Thank you. Well, that's very common. It's this kind of injuries with they are run over. So Mari, can you go ahead?
Okay. So we try to.
Did you do a fast? Did you do a fast exam just for curiosity? Yeah, and it was negative, positive?
It was positive.
Wow. Let's see.
But we got the images from the referring hospital.
Oh, yeah.
The portal phase, we got the images reviewed at the time.
That's rare, good and rare.
Yeah. So the portal phase was really early.
You're right. Seems like an arterial phase.
Yeah, it's a arterial phase.
Wow.
And there's the late phase. Do you want me to?
Did they mention this hemothorax on the right side or something like that? Because seems to be a little fluid.
Yeah, we noted it.
Yeah.
A small amount of.
Yeah.
Fluid.
And there's in my opinion, you have the kidney injury, but in the pelvis you have big hematoma with some kind of blush inside it. Do you agree with Dr. Antrach? Doctor, can you see
Yeah,
this?
no, I see. You know, they said hematoma, right retroperitoneal, but that's huge.
Huge.
Organic hematoma, and that right there would be responsible for the hypotension. But that was at the time at the other hospital, and the issue is how much more bleeding occurred in between. And you know, you can what you either just repeat the CT or judge on the ultrasound if do you think there's more bleeding or the same. But but that's a serious injury on the right side.
Would you go directly to the angel with these images?
That's a possibility. You know, if you did the fast, and I agree with Dr. Hockman, but you can also get a sense, okay, the liver's intact and the spleen's intact. And if there's no free hemoperitoneum, you know, maybe the positive fast, you're just saying that the effects of that hematoma, which is retroperitoneal. And if that's the case, intact spleen, intact liver, not a huge free intraperitoneal mass of blood, which is easy to spot, then yeah, I think that's an absolutely reasonable strategy. Go straight to IR and squirt the problem's going to be on the right side. and see if there's any active bleeding. Yeah, and then the pelvis went by quickly, but it seems like it's fractured, but not badly disrupted, unless I missed it. It went by quickly, but
she's with the sheet. It's kind of there is something there. Or Mari, can you help us with this information? Do you know if at this point she was with the binder or the sheet around the pelvis?
Yeah, she came to our hospital with the
But
sheet.
the moment the CAT scan was done.
No, it was after they saw there was a pelvic fracture and she wasn't stable. That was what we understood from it.
That's the point. Dr. Ontrat said there's not a bad injury like an open book or something that would have but there's a lot of bleed there. What do you do, Dr. Hoffman? Would you go to the angio directly? You're trying to consult with the orthopedics. There is this free fluid, this positive fast. I'm not sure. It's difficult not to take this patient to the OR.
My microphone was off.
So let's go.
This looks like a very unstable pelvic fracture. It has anterior component and has posterior component in the right iliac joint. So I don't know. This is probably with the binder on, because otherwise this will be wide open the way it looks like. It's kind of look compressed. This is the case that the binder will work. It's a massive bleeding there on the right side, doctor. The only thing I'm not sure, it looks to me, because it went too fast, that might have an injury in the inferior pole of the spleen. Still, this patient will go to IR for me, but I wasn't sure if it was an injury in the inferior pole of the spleen.
Let's see again. Is this information in the report?
Just pass near the end. If you can stop near the end, it's an injury in the inferior pole of the spleen. There is an injury there. Yeah,
right.
Yeah,
right.
And but the pelvis is very unstable. The both pubic ramial fractured, the acetabular is fractured, the right sacroiliac joint is fractured. So this is a variant of an open book. I don't know how the pubis rami was. If they were separated, the symphysis was separated. You see, there's a fracture there on the right. And when you go here, both this is all fractured there. So this is really an unstable fracture. Granted, yeah, this is a kid. Maybe this is some of the growing plates. I don't know, but it's really a very bad pelvic fracture for a kid.
Let's see if is there some comment in the moral of LM. Well, no comments in the chat. You can go on. Mari, can you show us what happened?
Yeah, I'll show also the late phase of the CT scan. It has it has a lot of artifacts because she was agitated. They decided to intubate her soon after. Sorry.
Well, they use fentanyl and midazolam. This is not a good thing to do in shock patients, unstable ones. Wow. The collector system on the right is probably disrupted.
Yeah. I'll show one more time.
Okay.
Urine.
Their extravasation, yeah. Extravasation of urine. Well, but this certainly is not skinning her at this moment. Yeah. Dr. Horman said IR. Dr. Untrach also think like that. Mari, what did you do?
Okay, so she had this right kidney injury. I'm sorry, I put it left here. There was urine extravasation, that small amount of fluid in the left hemithorax, and lots of fractures in the pelvis and also the left femoral neck. Actually, right femoral neck. And The ortho said was consulted. They deemed that the fracture was a lateral compression and wasn't unstable, mechanically unstable. The patient, during the initial assessment, she became hemodynamically unstable. She had the blood products already. She was acidotic, and her heart rate jumped to 146. The blood pressure dropped to 76. Neurosurgery was consulted because of the fractures in the vertebra. It was conservative and no need for spinal cord injury care. And ortho said there was no indication for external fixation. The symphysis was closed. There was this left femoral neck fracture that they planned on operating when she was stabilized.
Mari, what about this PCO2 of 72 and that pneumothorax? Would you be worried about that?
Yeah, actually, I think the problem was with the ventilation
Ventilator.
parameters.
Oh.
Yeah,
Mhm.
she had a metabolic acidosis and also a respiratory acidosis. I believe because of the mechanical ventilation. Okay, so at this point, she was already receiving blood products at our hospital. We started her on vasopressor, small dose, and her folate had no urine output. Then it was decided to take her to the OR. The sheet was removed.
Yeah, I'd like to make a comment on that. It's I've seen, I'm sure you too. The CAT scan without a cystogram is not sufficient to rule out intraperitoneal bladder injury. So if you didn't do the cystogram, she may have this injury too. For example, a rupture of the cranial part of the bladder.
Okay. Does anybody think that she's still a candidate for non-operative management, or?
You mean for the abdomen or for the there is a question in the chat that's put together. Any experience with pediatric pelvic packing? Well, let's ask for our panelists here. Dr. Hoffman.
Dr. Untra was raising his hand before me, so.
Go ahead, Dr. Hockman. I can wait to hear it. You go ahead.
No, with pediatric pelvic. I have experience with pelvic packing, but not with pediatric pelvic packing. I would probably do the same if I be forced to address this. But I have an issue. I disagree with the orthopedic surgeons that this pelvic is stable. It's fractured in two places. The pelvic ring is disrupted. And based on the location of the pubic rami fracture that are being pushed inward, I think this is being compressed by the binder. So I will be very concerned that the type of fracture is more like a AP compression than lateral compression. I will be very concerned about removing the binder on this patient because he will become unstable. So exactly. You see extravasation, I would probably go to IR first to see if it's anything that can be embolized. She has a huge retroperitoneal hematoma. I've been there in the abdomen with ruptured retroperitoneal hematomas. Yes, it can be packed. It's complicated, but it's a complete mess. So I would like, if possible, particularly in a kid that you have very little room to work, if they will embolize first before I will commit myself to surgery. I will correct the PCO2. This is a respiratory acidosis. But that would be, I don't know, maybe I'm totally wrong. It's a pediatric patient, maybe they are different. I always joke that pediatrics is so different. There should be a different medical school, like veterinary. But I don't know. I would go IR first.
Thank you. Dr. Zapata, Roberto Zapata Calderon raised his hand. Can you open for him, Kevin?
Yes, he can unmute. Yeah, yeah. Hello, Dr. Zabata.
Dr. Zapata, can you make a question, or do you prefer to write down in our chat? I'm not sure, Dr. Utrecht.
Yeah, I'd make a comment here. So you said decision to operate in your box over there. You gave more blood products, did you, at this point, and the patient didn't respond? Is that right? She did not respond.
No.
Okay, and I think that, at the other hospital, they probably didn't give her tranexamic acid, and it's too late now. But so she's not responding, and so you need to really get control of the bleeding, and and I certainly sympathize with what Dr. Hochman says. And initially, if she were responsive to the blood products, I think certainly reasonable to do IR. I don't think in this case you did that. I'm just guessing. But if the orthopedist said, no need to operate now, she's got multiple fractures, but the ring is basically in the normal configuration because it's a child with, more squishy bones, that aren't quite as brittle yet and rigid. And and also the fractures are on the left side, the femoral neck fracture and the other fractures. But so is she IR would be great if she was bleeding from the pelvic vessels, the arterial, the pelvic arteries off the internal iliac. And in this case, she's got all the trauma up near the renal pelvis, extravasation of urine, and probably that's the source of bleeding. So if the bleeding is really from the kidney or the renal pedicle, which I think is where the money is, that's where the hematoma is biggest. If you went to IR, you could probably, even if it was there, you can control it that way. Or if you decided she's too unstable, she's not responding, she's getting she's pale and not developing better refill, that you need to operate on her. But I think what you need to be prepared to do, you can operate and not find anything in the peritoneal cavity to fix. You're going to need to do a Cattell maneuver, access the retroperitoneum on that side, and in which case you're going to get a fair amount of bleeding. So, for control, just control the aorta near the diaphragm, and then look at the kidney, and maybe the bleeding is all from a disrupted kidney that you might have to remove or partially remove, or from the pedicle that you might be able to fix. I think a very skilled, expeditious radiologist, interventional radiologist, might be able to get better control if it's the renal pedicle, if it's the kidney itself. I don't know that they can embolize if they see a major bleeder. But either. I think that Dr. Hochman's plan is reasonable. Go there. If they can get in quickly, they can save her life, depending on where it is. Likely not the pelvis. It might be the kidney, but either one, they can identify it and fix it. But if you operate, it's gonna it'll be more difficult, but you can fix it also. But I think the problem is going to be around the kidney on the right side anyway.
Yeah, actually, we don't have embolization here, so that wasn't
enough.
Okay, so that settles it. So that
yeah.
So there you go. But I'm guessing that well, there you go. Dr. Hochman wants to say something.
This is the beauty of this conference. We need to solve the problem with the tools we have, and that have happened many times. I will do this. Well, we don't have this here. So if you don't have embolization, yes, you are stuck. This is something that I hardly ever do. I usually criticize people when they do this, and I am going to recommend what I always criticize. But in a patient like this, I would probably repeat the CT scan. And the reason to repeat the CT scan, Dr. Unter has very good points there. The bleeding is probably coming someplace near the kidney. And I have seen from blunt injuries, because people tend to think that those injuries are usually penetrated. I have seen complete avulsion of the right renal vein. I have seen transection of the IVC, not once, but twice from blunt traumatic injuries. So it will give you a better idea when you go, because you are going to have a huge retroperitoneal hematoma, and it's very difficult in that mess, particularly in a little kid, where there is not too much room to find where the bleeding is coming from. So she was stable enough for several hours, 15 more minutes to do a new CT, maybe will give you more useful information. A regular CT, no CTA, because you will see the venous bleed too there, and if it's arterial bleed, you will see it. But it will give you a better idea when you're going there, everything will be bleeding, and you can tackle what is bleeding faster. So if it's an avulsed renal artery or renal vein, you go there, do a nephrectomy. If it's something below in the pelvis, the iliac vein or the iliac artery or something there, you go there first. Normally, I say that if you cannot deal whatever you find, you shouldn't be doing trauma, so no need to do the CT scan, but it's in a different patient. It's a patient who is very unstable and you need to go right away. This patient, you have a little bit of time, and if your only option is to go to the OR, try to get as much information as you can before going in. But this is kind of, again, there's a lot of caveats. Normally, I would never recommend a CT scan if the patient needs to go to the OR.
I got a question.
We have another consideration here. Dr. Frisbee, the question was Dr. Frisbee. Yeah, just 1 minute.
I got a question for you. When you went to the operating room, which is where we're going right now, you didn't take the binder off, did you?
Yeah, it was taken off.
You took the binder off?
Yeah, they.
Okay. That's
They
all
believe in the orthopedics. They have this point. The orthopedics said, well,
you're going to lose whatever tamponade you had. Oh boy.
But it was already, the pelvis was already in normal configuration, right? It wasn't open book, and it was, it was the ring with the fractured, but so I think that's the point. But
I totally agree with Dr. Frisbee here. You have the pelvic fractures, the pubic rami are both fractures, and the acetabular on the left side, and you have a sacroiliac joint on the right. So the ring is disrupted in two different places. So that is an unstable pelvic fracture until proven otherwise.
wow.
So I totally agree with Dr. Frisbee. I would not take out the
That's a good point.
But if I can just add to that, so once the patient was hypotensive before you took off the binder, and then you took off the binder, what happened? Did the patient's blood pressure fall further, or no change?
No
No
change.
Yeah, so I think.
Let me ask you.
So
sorry.
That's a bit of a clue as to what you might find, but I think the points of Dr. Frisbee and Dr. Hockman, I agree with that. You have to be careful when you don't quite know, but it's like taking a tourniquet off on an injured extremity. If you don't see the blood pumping out and the patient is stable, you can leave it off. But anyway, there you go.
Yes, the idea is that with the lateral compression, if you apply a force to close the pelvis, it could worse.
Make it worse eventually. Yeah.
Yes.
We have to work. We have to work with the information we have. But well, all of those are good points, Dr. Frisbee, Dr. Horn. I would consider it certainly the idea you have. But let me ask you. There are two questions here. There's in fact, Dr. Zapata said that he had 7 blunt laparotomies in this situation, and he probably thinks here that hemorrhagic shock is because of the pelvis. They asked about Reboa. Would you have an experience in children? Children 80 years old, Reboa, Dr. Untrach? Is it
No,
possible?
I don't know that they make them small enough. Number one, you can put probably maybe a large Fogarty catheter, but vessels that small, I think the high likelihood of high incidence of femoral vessel injuries. I don't know that it's been done, or might even be contraindicated in children. It's not necessary here, because if the patient gets really unstable, and that's the only thing that I would have maybe done another CT scan early on before she became unstable. And now, if you're saying she's not responding to fluids, and you know, you don't, and you're concerned that if you go to CT scan, it may be, you know, too much delay. You know, if you have to go to the OR, then, you know, you make your incision, put your hand up under the at the hiatus and get control of the aorta right away. That's going to be very quick, and then you can, you know, finish the laparotomy and open the rest of the incision and, you know, get control of the retroperitoneum. So in this case, I think that might be meddlesome to consider that kind of Reboa, whatever, you know, in a.
So go ahead to the OR.
Yeah.
Let's see what my did.
Okay, so she was actually operated by a pediatric surgeon that works in trauma with us. They decided for a longitudinal median incision. There was a large retroperitoneal hematoma, especially in zone 2. No active bleeding in the peritoneum. With the maneuvers, they found a complete urethral transection at the renal pelvis and a partial renal artery injury. So the kidney was deemed the source of the bleeding. There was a bladder distension, no bladder injuries upon the dissection, neither intraperitoneum or extraperitoneum, and the balloon was not palpable inside the bladder.
Wow.
So options now.
This is something. So the retroperitoneal hematoma in the pelvis was not that big.
Not that deep. The most
The huge hematoma was in the around the kidney.
yeah,
Okay.
exactly.
And how do you do to see all of this? So there are your surgical maneuvers there. So open the fascia, you put the kidney out, you put a clamp down, and you found all that. How did you do that? Because if you found these injuries before you sacrifice the kidney, sometimes when you have a continuous bleeding there, you have to sacrifice the kidney in order to prevent further exsanguination. But
Yeah.
how did you do this maneuver? Were you there with them, Mari, or not?
I wasn't there. I wasn't there in the surgery. I don't know, maybe they put a clamp or just put a surgical gauze with it and
I did. Would you like to comment, Dr. Rohan? Would you try to preserve the kidney in this child despite he's hemodynamically unstable? Why'd you do that?
Usually when we tackle the kidney in an adult, the kidney comes out. That's the reason we try to avoid the surgery if we can avoid the surgery. In the kid, I don't know. It depends how the kid is doing. If the bleeding was controlled and it's an easy repair, maybe try to repair. But really, I don't know the urethral transection at the renal pelvis, if it can be repaired or not. That would be a very difficult repair because of the vascularization. And if it's the ureter, mid ureter, yes, you can spatulate the ureter and do a repair over a double J catheter. But I had a feeling that at that level, the kidney will leak urine. So I don't think you have too many options there, but to take the kidney out.
Dr. Rotraci.
Yeah, so this, you know, if you had a hybrid OR or not even that, interventional radiology that is comfortable with kids, that would have been ideal. You know, you take her, you know, if you do the fast and you see, well, she got the hematoma, but not a lot of intraperitoneal blood, you know, and then the radiologist is saying, well, the pelvis is fractured in a few places, but not a big hematoma there, doesn't really need to be reduced. Then I think, you know, and you're seeing the CT scan, it's reasonable to go right to interventional radiology if you had them, because then you can deal with anything, but it's going to be the kidney. And in this case, there's a partial disruption of the right renal artery. So they could put a stent across that, and that sounds like it would have gotten control of the bleeding. She would have been stable, then no more hemodynamic emergency. As far as the disruption goes, the good pediatric urologist can put a nephrostomy tube and then electively, once the bladder can be intubated, do a scope and put a J stent, try and get it across the disruption, then leave a drain outside the kidney along the nephrostomy tube and let that heal. And that's it. The pelvic vessels would have been intact. But barring that, it's what you did. And I don't know, the way they did the operation, they must have done, immobilized the viscera on the right side, Cattell maneuver. And from what you described, if they could see that, you can just get finger control over the vessel and let the anesthesiologist catch up. If she's responding now and pinking up and you start to see urine coming out of the injury in the kidney, then you're good. Then I would try to repair, with double arm sutures. It sounds like if it's anterior and you can repair it, I would do that. See if you can do a repair of the ureteropelvic injury over a J stent that you can put through the injury up and down, and do a repair over that. And it would probably be okay. Leave a drain out the retroperitoneum, a good suction drain to remove any urine, and you're done. And I think that's what I would try to do here for an 8-year-old girl. If she were really unstable and was a mess of a kidney and you couldn't, the hilum was disrupted, then okay, you take out the kidney, she'll do fine. But I would try to save it in this case. And Dr. Hockman, he's wanting to say something. I can see there.
Yes, one thing that, and related to this, which I was just thinking, the balloon, she had bloated urethra, and the balloon is not in the bladder, and the bladder is distended.
Yes.
So this could be a very, and if you look at the pelvic fractures, there is one of the segments of the pubic ramage which is pointing towards the urethra. So I would be worried about a transection of the urethra from the bladder, which is really much more serious injury than the kidney. I will take the kidney out, no question, but this is a devastating injury she has this. So I don't know, maybe that would be worried. The ideal thing in this situation would be, if you have a pediatric urology, is to try to intubate the bladder from the urethra with a Foley and put the Foley into the bladder and retract that way. But this is the part I was a little bit concerned, because you can explore all this, and an extraperitoneal bladder rupture is very difficult to diagnose intraoperatively. How do I know? Because I miss them quite frequently. So that would be my worry now. I don't know. Please, Mariana, just educate us. What do you do with this patient?
Can I ask a quick question?
There's another question. Yeah, there's another question here for Dr. Mary Porta. Go ahead, Dr. Frisbee. Then I'll do Dr. Porta question after. Dr. Frisbee, no, you're on mute.
You're muted, Dwight.
As a practical matter,
yes.
You said you took the pediatric surgical fellow who does the trauma with you went in there. What's his OR report say he did? I'm just asking. He's AWOL, so we can't ask him.
Yeah, yes. He's I don't know if he's here. Let me see. But he's a very skilled.
Yeah, I understand that, but my question is, what did he write down that he did, so we could go back and critique it?
No, let's see what I do.
Yeah,
why don't you? Let me ask you this question too, Dr. Mary Porta. She said, well, this is an unstable kid and we do damage control. Take out the kidney because you don't have. So I think it's a point here. We had an unstable patient here. We are eventually trying to save a kidney in the risk of losing her life. I'm not sure, perhaps I'm not a pediatric surgeon as you, Horacio. I would probably take the kidney out and I would be in the ICU as soon as possible.
No, I am not a pediatric surgeon, and I would probably take the kidney out. No, we are in agreement.
But what about the bladder?
The bladder is the thing that really worries me. It would have to have a cystoscopy, and if it's possible, advance under direct vision a Foley into the bladder, inflate the balloon and pull back from the balloon, trying to see that healed, praying that the sphincter is not damaged. But this is a devastating injury if she has this. It's urethral injuries are rare in females, but when they happen, have much more devastating consequences than males. In males, usually you can put the two ends together. In females, it's much more difficult to succeed. So it is possible that she will end up with a suprapubic cystostomy.
Yeah.
That would be tragic. That would be absolutely tragic for this poor girl.
Well, let me, we are ending.
Can I ask vesicoma? Is that just a hematoma in the bladder? Is that all it is?
Yes.
Okay.
Is not a hematoma. Is the bladder is
Ended, yeah.
You got there is no way out for the urine. You know, it is transected. The urethra is transected, so she could not urinate. They couldn't put a Foley inside, you know, from the other side.
Well, I think a urologist could decide. I would just call them, the pediatric. But Dr. Alex wanted to say something.
Yes, please, Alex, please.
Good morning.
We're hearing you. Yeah,
can you hear me? Okay.
Hearing you. Yes.
I'm sorry. I put the questions in the chat. I think it would be nice if there is some sort of accessory renal artery on the right side, then maybe the kidney may still be perfused, and all you deal is with the main inflow if you cannot repair it. And then if my other question was, how long was the ischemic warm time? Because if it's prolonged, then it doesn't matter. And if you don't have any accessory flow to that kidney, then it doesn't matter anymore, really, even if you think you could reconstruct it. And I agree with what was said, all the comments, including stopping the bleeding. But those are my two comments. Thank you.
You're welcome. Well, we still have 10 minutes for ending all this discussion. Mari, can you go ahead and go to the end of the case, please?
Okay. So as she was unstable and considered as a non-responder, they performed a nephrectomy and decided to open the bladder to place a Foley under direct vision, like the railroading, which was they didn't find any bladder injuries upon the opening of the bladder, and passed the Foley using the railroading. We don't have a cystoscopy here, unfortunately. And then the fascia was closed, the abdomen was closed, and she was taken to the pediatric trauma ICU. She got a little better, heart rate 133, blood pressure 108. She was still with norepinephrine, 5 milliliters per hour, and her urine output was borderline for a children's goal. On the first postoperative day, she was still unstable. They had to put also adrenaline as a vasopressor, and she developed kidney injury, rhabdomyolysis, and still had this borderline urine output. On postoperative day 2, she was reducing vasopressors, she was extubated, and they began liquid diet. And on postoperative day 3, she was already stable, improved the urine output, and went to the OR to fixate the femoral neck fracture with the ortho. She is still at the hospital. Today is her 6th postoperative day. She's stable with normal diet. She has a vaginal bleeding, a small amount of vaginal bleeding. It was inspected, but no injuries were identified, but maybe there is a small injury. And the plan is to keep the Foley for 7 days to mold the urethra and maybe do a ureterogram as well. But she's doing fine despite the severe trauma. So any comments, questions?
Well, this is a hell of a case, man. You know, let me tell you that very curiously, we had a very similar case in the mechanism here, perhaps 2 years ago, two weeks ago in Santa Casa, and they filmed exactly the same thing. The child is not a 14 years old boy, and he tried to run, you know, beside the bus, and he kind of goes, one of the legs goes down and is run over, and he had a very bad pelvic fracture too. So, well, I'd like to congratulate you. Great case, great maneuvers. We learned a lot today. Dr. Untrach, last comment,
Yeah,
please.
great case. You know, anybody can look like a real star in a place where you're surrounded by all the best of everything, right? You see Dr. Hochman nodding, where you got all you want to be at a place where you got all the experts, but you gotta mark your time in remote locations, and whether it's the developing countries or where you have limited resources. And you got to be a good surgeon there, because you probably don't have a robot, because eventually the robot's going to do the surgery. They had Hopkins, they did a lap chole without a human. The robot did it all by herself with no people there. So they're going to do it. But so here you didn't have the option for interventional radiology, and you didn't even do a single X-ray here, just an ultrasound. You went to the OR, and you have to be good. I think it's reasonable to take out the kidney. And I wasn't there, but under the right circumstances, I would have put my finger on the bleeding point and see if the patient stabilized. And then, can you save the kidney? In this case, she had two injuries, the uropelvic injury and the arterial injury. So you just solved a big problem by just taking out the kidney, and she'll do fine with one, as long as she doesn't, do what she did again, walk in the curb, in front of the bus. But I think she probably won't. But really, really well done. I'd be interested in how the surgeon did the operation. Did he do a Cattell maneuver? Did he go right through into the hematoma? I think it might be easier to do it anatomically, so you can get right to the, expose the vena cava aorta and see the vessels, and it might be a little easier. Sorry, go ahead. You saying?
Yeah, they reported they did a Cattell brush. Yes.
Right. So all beautifully done. I think also in this case, why the bus didn't kill her, it seems like she got pushed into sort of a channel between the curb and the asphalt, when the road curves, and then so the wheel was a little bit off on the outside of the wheel, crushed her, but didn't totally, so it took kept a lot of the weight off. So she's a bit lucky, but she could have been luckier, and I hope she knows not to do that again. Poor thing. So, okay, but very well done. You're good surgeons there.
Dr. Frisbee.
Oh, first, a couple of things. Number one, if you can stay out of the pelvis, you need to do it. Don't go near it. It is a jungle, and it will be a sea of red like you've never seen before. But that's just my personal opinion. If you can stay away from the pelvis using whomever and whatever facility you have, I would encourage you to do that. The second thing is, the real teaching point here is, when do you have to take this kidney out to save this kid's life? And I think that is really where this all comes down to.
Exactly.
It really becomes an issue for someone's psyche to take care of. And as a result, it has to do with experience. It really does. And in this case, it was done well, very well. Nice case and very well done. Still like to talk to the pediatric surgeon, though.
Dr. Hohan.
No, my comments are going to be along the line of what Dr. Untra said. It's very easy when you have all the technology, and I call this and I send it to IR, and if from there I send it to MRI and the hybrid room. But when you don't have it, that where the quality of the surgeon counts. And so I congratulate you. This is a terrific case. We have the luxury of having all the extra technology, and you show us that you solved this case with no technology at all, just by being a good surgeon. So congratulations. And this is the beauty of this conference. We present cases and we hear, no, I will do this, I will do that, and all depends on what you have. And the important thing is the result, and you got excellent results. So really, double congratulations to you.
Well, thank you all. Thank you very much for your participation, your comments, especially Dr. Antrach, Hoffman, Frisbee. You know, this meeting, it increases a lot in terms of knowledge when you participate. I invite you to continue participating in our SBITE meetings. Dr. Mariana, thank you very much for that. Hospital do Pronto Socorro is a very recognized trauma center, and we learn a lot from it, and we continue to learning. Thank you very much for that. Kevin?
Yes.
Let me say, Dr. Mariana is an attending, not a resident or a fellow?
Whoa. Well, you have to say she is an attending. Yeah.
Dr. Umtrak, we are getting old. That's what's happening.
Yeah. The attendings are starting to look like the fellows.
I think Dr. Kumaira
it's not that the
it.
attendings look so young. We are too old.
Yeah, that's okay.
Speak for yourself, Horatio. Talk for yourself, Horatio.
Yeah, that's good. That's right. Kevin, is everything okay?
Yeah, I put the CME link in the chat.
Yeah.
I'll leave the meeting open for a little while for those of you who need to go ahead and click on it. But that's it. That's all I have.
Thank you. Thank you all.
Thank you, everyone.
See you later.
Bye-bye.
Thank you. Bye-bye.